Every second person after the age of 50 will notice floaters in their eyes. When we say floaters, we mean tiny moving dots or thread-like shapes inside the eyes that drift across the field of vision. It's important to understand that these floaters are visible only to the person who experiences them. Others cannot see them. Most floaters are harmless and related to normal aging changes in the eye's vitreous gel. However, sometimes they can signal serious eye problems that need urgent treatment. That's why I will tell you the top 5 causes of floaters, how to treat and prevent them, and what their prognosis is. The first and most common cause of eye floaters is age-related vitreous changes, called posterior vitreous detachment, PVD. Our eye is filled with a transparent gel called the vitreous body, which makes up about 80% of the eye's volume. This gel is about 99% water, held together by a fine network of collagen fibers and hyaluronic acid. With aging, this gel gradually loses its water-binding ability and becomes more liquid rather than gel-like. Collagen framework shrinks and collapses slightly. As a result, the back layer of the vitreous peels away from the retina, and the person starts to see floaters. Usually, these appear as 1 to 3 floaters, and their number remains stable, developing slowly over days to weeks. The floaters move with eye movement, which is the classical sign of vitreous body origin, and indicates that this is not a retinal detachment, a much more serious condition. Floaters are most visible on bright backgrounds, such as when looking at the sky or a computer screen. Vision remains stable, and color perception stays normal. Diagnosis is made by a dilated fundus examination, which confirms vitreous separation from the optic disc while the retina remains intact and safe. This condition occurs mostly due to aging, when collagen and hyaluronic acid lose their stability or during oxidative stress. It is also more common in myopia nearsightedness, where the longer eye stretches the vitreous. Posterior vitreous detachment is extremely common, affecting about 50% of people after age 45 and even more after age 60. Before 40, it still affects around 10% of people. Eye surgery and trauma can also contribute. Usually, no treatment is needed, as floaters often fade or the brain learns to ignore them. If the floaters become visually disabling, possible treatments include laser vitreolysis or surgical vitrectomy. There are no specific preventive measures, but wearing sunglasses, avoiding smoking, and maintaining hydration are important. Antioxidants such as vitamin C and lutein may help support collagen and retinal membrane health. The second and important cause is retinal traction and tear. Our retina is a delicate, light-sensitive film that lines the inner wall of the eye. It works like the sensor in a camera. The vitreous body, the clear gel filling most of the eye, is normally attached to it. With age or myopia, when the vitreous begins to shrink and detach, tiny adhesions sometimes remain between the vitreous and retina. And here is the crucial part. When the vitreous moves, it can tug on the retina. This tug acts like pulling on a nerve ending. The retina reacts to that mechanical traction by sending false light signals to the brain, and you suddenly see flashes of light, called photopsia. These flashes are most visible in the dark because there is no competing external light, so the false signal stands out sharply. If the traction is strong enough, it can tear the retina itself. When that happens, fluid from the vitreous may seep underneath and start lifting the retina off the wall of the eye. This process is called retinal detachment, and it can lead to permanent vision loss if untreated. The early warning sign is very characteristic. Instead of 1 or 2 stable floaters, you suddenly notice a shower of new floaters. Dozens of tiny dots or threads appearing almost overnight, sometimes with flashes at the edge of vision. Another red flag is a dark curtain or shadow slowly moving from one side of the visual field. That curtain means the retina has already started to detach. In such moments, time is everything. Within hours to days, a small retinal tear can progress to a full detachment. That's why doctors say new flashes or sudden bursts of floaters equal to same-day eye emergency. Diagnosis is made by a dilated fundus examination. The ophthalmologist inspects the far periphery of the retina under special lenses. If a tear is found, it is sealed immediately using laser photocoagulation or cryotherapy. The procedure creates a thin scar that prevents the retina from peeling off. If detachment has already begun, surgery such as pneumatic retinopexy, sclerobuckle, or vitrectomy can restore vision in most cases, especially if the macula is still attached. When treated promptly, the prognosis is excellent. Over 90% of retinal tears can be fully sealed before detachment develops. But if the macula detaches, visual recovery is slower and often incomplete. There is no medication that can prevent a retinal tear. But the most effective prevention is awareness, recognizing flashes, sudden floater showers, or visual shadows, and seeking immediate care. Wearing protective eyewear during sports or work, controlling myopia, and avoiding severe eye trauma also reduce the risk. The third common cause of floaters is migraine with aura. Sometimes the very first sign of a migraine is not pain, it's light. You may suddenly notice shimmering zigzags, bright arcs, or flashing C-shaped lines spreading slowly across both eyes. The world looks like it's made of broken glass or dancing light. And then, after 20 or 30 minutes, a headache begins. This experience is called a migraine aura. It happens in about 1 out of every 4 people with migraine, which means around 4 to 5% of the whole population. It's frightening when it first occurs because it feels like something is happening inside the eyes, but in truth, it's happening inside the brain. During an aura, a wave of electrical change called cortical spreading depolarization passes across this area. It's like a ripple on a calm lake, moving at about 3 millimeters per minute, turning normal activity off and on as it travels. As that wave crosses the visual cortex, you actually see its electrical footprint, shimmering zigzags, geometric shapes, or flashing edges that expand gradually across both eyes. Because it originates in the brain, not in the eyes, the pattern is bilateral, visible even if one eye is closed. It usually lasts 5 to 30 minutes, then fades, often followed by the classic throbbing headache, nausea, or profound fatigue. The fourth cause of floaters is cataract. Inside our eyes, we have a lens that should be perfectly transparent. For most of life, it remains clear as glass. But as the years pass, light itself slowly leaves its fingerprint on this lens. Every day, sunlight, oxygen, and metabolism create tiny molecules called free radicals. These free radicals attack the proteins in the lens, oxidizing, cross-linking, and stiffening them. Gradually, the proteins lose their perfect arrangement and start to scatter light instead of letting it pass smoothly. This slow clouding process is what we call a cataract. It develops mainly because of oxidative and glycation damage. In simple terms, sugar, oxygen, and time slowly change the chemistry of the lens. The once clear proteins become yellowed and opaque, forming tiny clusters that act like countless small mirrors. Each mirror reflects and refracts light in different directions, leading to visual disturbances. The most common signs of cataract are night glare and halos. Lights appear surrounded by rings or spikes. Increased sensitivity to headlights or sunlight. Vision feels too bright. Gradual, painless blurring of both distance and near vision. Color fading or yellowing because the lens filters more blue light. The retina and rest of the eye remain normal. Only the lens shows clouding when examined under a slit lamp microscope. The best news is that cataract is completely curable. Modern cataract surgery, called phacoemulsification, uses ultrasound waves to dissolve the cloudy lens and replace it with a clear intraocular lens, IOL. The operation usually takes 15-20 minutes, performed under local anesthesia, and recovery happens within a few days. The fifth cause of floaters or floater-like visual disturbances is corneal surface disorders. The cornea is the eye's first and most powerful lens. It should be clear, smooth, and dome-shaped. Although it has no blood vessels, it stays healthy through a constant supply of tears, oxygen from the air, and nourishment from corneal nerves. When the corneal surface is clear and even, light enters the eye like through a spotless window. But when the surface becomes dry, swollen, or irregular, light begins to scatter. This makes the world appear hazy, doubled, or surrounded by halos. People describe it in simple terms. My vision blurs when I read for too long. It clears when I blink, but goes fuzzy again. It burns, and it feels like sand in my eyes. This combination, fluctuating blur, burning, and relief after blinking, is the classical hallmark of dry eye disease, the most common corneal surface disorder. Treatment focuses on restoring the tear film and protecting the cornea. Artificial tears or lubricating gels help rebuild the tear layer. Lid hygiene and warm compresses unblock the meibomian oil glands. In more persistent cases, anti-inflammatory drops such as cyclosporin, Restasis, or Levetras Cidra improve natural tear production. Humidified air, avoiding smoke and wind, and frequent breaks during screen time also make a major difference. Other, less common causes of floaters include inflammatory debris from uveitis, approximately equal to 5% vitreous hemorrhage from diabetic or hypertensive retinopathy, approximately equal to 2% ocular trauma, approximately equal to 1% post-surgical changes after cataract or retinal surgery, approximately equal to 1%, and rarely intraocular tumors or infections.